Chronic venous ulcers. What are they? Who gets them? How do you treat them? Welcome to Talking with Docs. I'm Dr. Brad Weenie.
I'm Dr. Paul Zalzan. We have an amazing guest. He is back. He is back. Dr. Chuback is back.
We are back, baby. We are back. Classic. We are back.
Thank you very much. Good to be here, guys.
Thanks for coming, John. This is a really common problem, very debilitating for so many people. Let's start at the beginning. What is a venous ulcer and why do people get them?
Well, venous ulcers, they go by several names. Going back to when we were residents, we used to call them venous stasis ulcers. You probably remember that. Venous leg ulcers, VLU, is a common moniker for them now. Basically, they are the result of long-standing chronic venous insufficiency, which we all talked about recently on another episode. And you get blood pooling in the legs, high pressure in the veins, and that pressure gets translated right down into the microcirculation, and that microcirculatory problem basically causes necrosis of the skin, and it can be a really, really difficult problem to deal with.
I think they're so important, and people underestimate the importance of it because they think it's something wrong with their skin, but really it's a vascular problem that's manifesting with skin issues, right? And skin, I think, is underrated. It's our largest organ in our body, plays a crucial role, right? Temperature regulation, protection. It protects us from bacteria and viruses and things. And now if you have a hole in the skin, you have a problem, a real problem.
Yeah, it's a tremendous problem. And that's why I always remind patients that I say, Paul, that it's the biggest organ on the body because people think it's just a pretty covering. But as you said, it has a huge number of functions. Immunological is amongst the highest, as you pointed out. And that's why there's an entire field of medicine called dermatology, contributed or dedicated to taking care of skin problems and skin diseases. But if one person out there is watching, other than, the lay public, I would love dermatologists to hear this because dermatologists are seeing too many venous leg ulcers that they're not recognizing the underlying problem and referring them for proper care and treating them as a local wound as opposed to a systemic problem, which it really is.
And I think that's a really great distinction is that a lot of people probably mistake them for either arterial ulcers, so a blood supply problem, which is not the cause of a venous stasis ulcer, or a diabetic ulcer, which also relates to the microvascular supply to the skin because of your diabetes. They're a very distinct entity and that are very unique in not only their diagnosis but their treatment as well and who gets them. So let's start then. So how would someone develop a venous ulcer, or why would someone get a venous stasis ulcer?
Well, typically this is on a sort of a scale of disease severity that starts with underlying venous insufficiency, typically in the saphenous vein, sometimes the small saphenous vein in the calf area, but you wind up with venous hypertension. It can also occur, importantly, as a result of what we call post-thrombotic syndrome in people who've had DVT or deep vein thrombosis in the past. They have scarring and insufficiency in the deep system of veins. So any kind of vein problem in the leg that's going to cause blood pooling in the leg causes that venous hypertension. The early signs of venous hypertension tend to be symptomatic, just heaviness, aching in the leg, sometimes night cramps. This is a sign to the patient that something is going wrong. Over time, edema will form, okay? That's what we call stage 3 chronic venous insufficiency. And that means you're progressing along that path toward an ulcer. Stage 4 is when we start to see trophic changes or skin changes, especially hemosiderosis, which is that brown, brawny discoloration of the skin that comes from iron pigmentation leaching out into the skin and causing what I call sort of a biological tattoo.
Right.
But that biological tattoo, that iron pooling and collecting and staining the skin leads to a massive inflammatory response.
Okay.
And it's that inflammatory response, or at least partially, it's also a microcirculatory problem, but that inflammatory response that leads to the necrosis and breakdown of the skin. So if patients are starting to see swelling in the leg, discoloration of the leg, what we call venous dermatitis, where the leg becomes itchy and scaly, venous eczema, which again, dermatologists will sometimes mistake that for just garden variety eczema.
Right.
Those are all signs that you're on your way to a venous leg ulcer.
And I guess that's important to recognize, because if you can recognize that you're on the way to a venous ulcer, then you can intervene to stop getting the ulcer or to prevent getting the ulcer, presumably.
That's massively important, and it's good to be speaking to orthopedic surgeons about this subject, because the most common areas that venous leg ulcers form is on the medial malleolus or the lateral malleolus, so
Around the
inside
ankle.
or outside the ankle. And even for very, very heavy patients who are obese, there's very little soft tissue, generally speaking, covering that malleolus. So when the skin there breaks down, the bone can be exposed, and then you can get into an osteomyelitis, and then you can have an infection that's very, very difficult to eradicate.
Sure, osteomyelitis infection in the bone. And that area there, I mean, it's just so sensitive. You see people who knock their leg on a coffee table, for example, and they get a wound there, and that can turn into an ulcer, a different type of ulcer, but that can take a long, long, long time to heal. And we've often had to cancel surgery because of these kinds of venous ulcers and other sort of traumatic injuries that take months to heal in that area.
And sometimes years, and sometimes never heal, unfortunately, despite heroic efforts, including all kinds of surgical intervention and grafts and everything else. But one of the things that's important there too is that when that bone becomes exposed, the blood supply is also very poor.
Yes.
So there's a lack of soft tissue and poor blood supply in that area of the periosteum overlying the bone. So it's a real double whammy.
Okay, so we've talked about what a venous ulcer is, why you get it. But can we talk now a little bit about intervention or treatment for these, or prevention even?
I was going to ask the first part. So say you think you have one. You've had chronic venous disease. You have a little wound over your medial malleolus. You go to your family doctor. How are they going to make the diagnosis? Is there a specific diagnostic test where they say, okay, you got the positive venous ulcer disease, test positive, we know that you have it, or is it more nuanced?
Well, we talk about this also. First, let's all hope that the doctor does a proper physical examination, because too frequently, physicians today who are busy, overworked, and this is not an excuse, this is bad medicine, quite frankly, they don't take the time to say to the patient, show it to me. The patient might say, doc, under my pants, under my sock, under this bandage, I have this wound.
Right.
And more and more, primary care doctors especially, are really not interested in seeing that. So you have to insist that you get examined by the physician. You say, let me show it to you. Let me take this off and show it to you. 95% of the time, the diagnosis will be made on physical examination and recognition.
Right.
Knowing what that is and what it looks like, and taking a good history, knowing the patient has a history of venous insufficiency, swollen legs, et cetera, et cetera. But if there's any question, that physician should certainly send the patient to a vascular specialist, preferably a vein specialist, because there's a big rift now growing between, not that there's an argument, but just the expertise between arterial surgeons and venous specialists.
That's a new thing.
Yeah, and so many arterial surgeons who are very busy doing vascular reconstruction for ischemic disease, where you're not getting enough blood flow into the leg, they just don't have the knowledge of recognizing and working up venous disease. So that workup would include, right out of the gate, a good duplex Doppler ultrasound exam to look at the underlying venous system.
Okay, so that looks at the flow through the veins. And so if there was a concern for the arteries, theoretically you could consider an angiogram, but probably you can rule that out with history and physical exam. Is that fair to say?
Absolutely. We would begin with another ancient but simple technique, which is checking pulses.
Right.
Right. You want to check pulses at the femoral level in the groin, behind the knee, at what we call the popliteal artery, and on the inside of the ankle and on the top of the foot. And any good primary care physician should do that. And it's not a foolproof test, because even with normal pulses, sometimes, especially in diabetics, they can have what we call small vessel disease, and they can have microvascular disease. But the big difference is, if you're a viewer out there and you have a wound, typically those ischemic wounds and diabetic wounds will be more on the toes, at the very, very tips of the feet.
And the ones that are caused by arterial disease.
By arterial disease. There are exceptions to every rule, but that's a very good rule of thumb.
And the vessels, essentially.
Correct.
Rule of toe.
Yes, that's a rule of big toe.
Right.
So the physician should be able to recognize that this looks like a venous leg ulcer based on the fact, especially if it's classic and it's on the medial malleolus or the lateral malleolus. Get them to a vein specialist, check that venous function, and rule out any underlying arterial inflow problem too.
Okay.
Now, can we talk about why people are watching here? Prevention and what to do about it if you have one.
Okay. Let's start with treatment.
Prevention. And
Prevention.
treatment.
Forget
Yeah.
what he said. Prevention.
Yeah.
Because you don't want to get it.
Well,
Yeah.
they in a sense, prevention is treatment.
Okay.
Because you're preventing the venous leg ulcer, hopefully, from forming, but you are treating the chronic venous insufficiency.
Right.
So the chronic venous insufficiency gets broken down into basically two big buckets. One is conservative treatment, and the other is interventional treatment. So the conservative treatment, the mainstay of conservative treatment when you have venous insufficiency is compression therapy.
Sure.
Graduated compression, we talked about this in our video on venous insufficiency, CVI. Graduated compression applies more pressure at the ankle, less pressure as you go up the leg. So if it's a knee-high stocking, it would be ankle, mid-calf, just below the knee. A thigh-high would be ankle, around the knee, and the thigh-high. The pressure getting lower as you go up toward the heart, and that is forcing blood from the high-pressure zone at the bottom up toward the heart, back to the right atrium of the heart. So that is hugely important. Elevation of the leg, exercise, weight management, quitting smoking, all of these kinds of conservative measures are paramount for good health in the venous system. And then if you find identifiable, treatable venous insufficiency, particularly in the superficial system of veins, then that should be corrected to the extent possible with endovenous laser ablation, ultrasound-guided sclerotherapy, microphlebectomy, etc.
Okay. So interventions for the venous insufficiency.
Correct.
Now, I guarantee someone's already started to type saying, this guy's crazy. There's no way I can get stockings on. So we hear this all the time, and I'm wearing stockings right now, and they're not prescription. They're a lower strength, so they're a little easier to get on. But they're certainly difficult, especially if your feet are a little bit wet right out of the shower. Mm-hmm. So first question, I guess, any specific advice for how to get these on better? I think we have one video that talks about this.
We do, yes.
But the second question I'd have is someone says, well, listen, I can't do the 30 millimeter, I can't do the 40 or whatever's been prescribed. Is there still benefit to doing something that's graduated, but it's over the counter and it's like, say, 10 to 15? Is it like something's better than nothing, but more is better?
Absolutely. I always use the dental analogy. Brushing your teeth once a day is better than not brushing them at all. I guess you should definitely go in the morning and before bed. Adding flossing would be good. So again, like anything else in healthcare and medicine, in many cases more is more. Yeah. But if you're going to do something, it's better than nothing. The other thing for people who have trouble with putting stockings on or just simply can't tolerate them, the micronized purified flavonoid fraction, the MPFF that we talked about, that's a dietary supplement that can be taken by mouth. But in terms of getting those stockings on, you're absolutely right, Dr. Wieman. There are a number of things to help you. There are stocking donners out there. Right. There are different devices that can help people to put those stockings on. There are lower grade compressions, like you said, rather than, let's say, 30 to 40 or 20 to 30, you might try a 15 to 20 or even less, because any compression is better than none. Yep. It should be graduated, though. Mm-hmm. If it's just kind of a compression sleeve, that's probably not moving the blood anywhere. Right. Probably not doing a heck of a lot.
Because theoretically, you can make it get stuck in the foot then, right? If it's not graduated. The thought is it's going to kind of milk it back to the heart, right?
Yes, especially if it's footless, which we see a lot of these days. People buy these sort of athletic sleeves, and then the foot can really become swollen. You can develop lymphedema and edema in the foot, which can be a real problem and is not always so reversible. But the other thing is there are other good options today, like Velcro wrap products that have been designed especially for venous insufficiency, that are easier to put on. And some of the companies are making active compression garments, either pneumatic or non-pneumatic, that are easier to apply. They don't pull on like a stocking. They wrap on with magnets or different mechanisms, and they will actually provide compression to pump excess fluid out of the leg.
Like a blood pressure cuff almost.
Exactly.
Yeah,
Yeah.
that's pneumatic as opposed to nomadic, which just get you moving everywhere.
That's right.
Okay.
One other question just about stockings for me. Some people are like, listen, I've been told I should wear the mid thigh. It's summer. What if I can only get to below the knee? Is that okay? Some people worry that if they wear shorter stockings that it's going to cut off the circulation at the knee and that's going to be a problem. Is it the same kind of principle that something is better than nothing?
Absolutely. And you do get all of those kinds of complaints depending especially on how a patient might be built, how heavy set they are, how heavy the thigh is and so forth. Some people do feel there is kind of a tourniquet effect around the knee. Typically, in reality, from a physiological point of view, anatomical point of view, that's not really the case.
Okay.
They don't really cut off the blood supply unless it were so tight, but in that case, you probably could never get that stocking on. So if it's a properly fitted garment, and that's a really important part of the discussion, if it's a properly fitted garment, you shouldn't have tourniquet effect, but you should see a specialist to properly measure you. That could be at the doctor's office, it could be at a lymphedema therapist's office, it could be at the surgical supply, etc. But you do have to have a properly fitted garment to have any chance of it getting on and or working.
Because we go to a hospital golf tournament, Paul often wears shorts and then his mid-thigh compression
do.
stockings.
Very nice,
It's
yeah.
a bit of a look.
Style.
It's a look,
really.
right?
Yeah. I keep them on. Okay, we talked a lot about Dr. Wiening's compression stockings. Let's move on to, let's say you do have an ulcer, okay? Someone has a venous stasis ulcer.
Yeah.
At this point, as the ship has sailed, are there some treatment options we can do now to help get this venous ulcer to heal?
Yeah, there's always hope, obviously. We never give up on any patient. So again, this is sort of a continuum, meaning that you can start with a very small ulcer and you can get a massive ulcer.
Right.
And that can be really a very challenging situation, what we sometimes used to refer to back in the clinic when we were residents, sort of an apple core lesion that goes all the way around the leg in a concentric manner and can be very deep and invasive, and it looks like somebody is kind of bitten all the way around an apple. So that's the sort of end stage of that process. The beginning stage, as Dr. Zalzal mentioned earlier, could be even a tiny little nick in the skin, and that should not be disregarded. No. Anytime you have a break in the skin, especially if you know you have venous insufficiency, you have skin changes, venous dermatitis, all those things, go see a dermatologist and or your vascular specialist, ideally, to nip that in the bud. As venous leg ulcers expand and grow, the things that we want to do to reverse that process is debridement of the wound, keep the wound nice and clean, remove surgically, sometimes a little bit of local anesthesia. This is typically an office-based procedure. You don't need to go to the hospital or the operating room for this under 99% of circumstances. You do what we call sharp curettage to remove all of the devitalized tissue, all of the dead tissue, and get a little bit into the living tissue, scraping that gently to get a little bit of blood flow, because that blood flow brings all of the elements of healing. Oxygen, nutrients, the white blood cells to fight any bacteria or infection that might be in the area. So debridement is essential, compression is essential, elevation is essential. Again, treating the underlying venous insufficiency is essential, and there are great studies for venous leg ulcer on micronized purified flavonoid fraction. It's mentioned by all, it's in the clinical guidelines of all the major vascular societies today for venous leg ulcer as a 1A recommendation. So systemic nutrient supplementation is also very, very important. And not to mention a good diet,
right.
Protein. You need those elements of healing, low sugar, low carb ideally. So these are the elements of wound healing for venous leg ulcer.
Okay, that's a mouthful.
It's a lot for sure. So with the compression stocking, some people are going to say, well, I got a big wound. You're telling me to put a compression stocking. These wounds are going to always be covered. Are there special kinds of dressings that people are typically using, or are there so many different choices that's going to be practitioner specific?
Yeah, the whole world of wound care has exploded since we were all residents. Yeah. We were basically back in the day using a lot of wet to dry dressings, meaning a little bit of saline solution soaked gauze sponge, cotton sponge, very mildly damp onto the wound to hydrate the wound. But when that dressing would dry, it will grab onto any of the devitalized tissues. So when that wound is removed, it's sort of debriding that wound with the wound change itself, which is a very effective way of doing it. And I'm an old school guy, and I still do a lot of that. The other old school practice that I still find very, very valuable is the old Uniboot application, which is basically a zinc impregnated, medicated, non-stretch cotton bandage that goes around the foot. It's like a barber pole fashion. We start around, and it can also be done as a figure of 8 compression fashion, but around the foot, should be put on by somebody who really knows what they're doing, and goes from basically the base of the toes to just below the knee, and that gives you excellent compression, non-stretch compression, which is important, and a little bit of that zinc antibacterial medication on there. That's another excellent, excellent bandage. But as you said, Dr. Weening, today there are numerous multi-level bandages out there, all kinds of gels, alginates, you name it.
Yep.
It can get very, very expensive, but I still believe many of the basic things will work for most patients.
2 other non-dressing related ones. What are your thoughts on back dressings as well as potentially hyperbaric oxygen? Because these are things that when we first started training, they were not around, and they slowly became popular for different roles. But does a back dressing play any role for chronic venous ulcer? And I know hyperbaric is mostly for arterial problems, but same thing. It's expensive, and it's probably going to be offered to people who sometimes are desperate. I just want people to make an informed, useful decision for themselves.
Yeah, these are both great points. I think that in the right patient, a vac dressing would be very, very good. Again, things have advanced tremendously in the last 20 years. Back in the older days, the vac dressings, which uses basically a sponge material and a piece of gentle plastic tubing that creates a vacuum in that sponge. It gets covered with a piece of, think of it as sort of a plastic wrap, a sticky plastic wrap, and that sponge sucks down and becomes very firm. It almost looks like, we always just say, it looks like a raisin when it's done. Because the sponge tends to be black, because otherwise it'll get discolored with the drainage from the wound. So they make it black so it doesn't look dirty and ugly. And when it sucks down, it looks like a raisin. And it's constantly pulling exudate and fluid and secretions out of that wound and bacteria. And they used to be more for deep wounds.
Right.
But they have these great new sponges and things now where it can be used very effectively even on a superficial wound. But for a superficial wound, it's probably still a little bit of an overkill. Okay. For bigger wounds, deeper wounds, I would say a vac is great. They're often covered by insurance. They often now allow you to be mobile, whereas in the old days you were kind of hospitalized, you were immobile, but now you can walk around them, little power pack. And then to the point of the hyperbaric, you're absolutely right. Hyperbaric is really more of an indication for arterial, and I don't think it's that it wouldn't be helpful for venous stasis, leg ulcers, from a theoretical point of view, but I'm not sure that the data is there so that, generally speaking, insurance would not cover it for venous leg ulcer.
Sorry if you like raisins.
Yeah. Not because you probably don't anymore. It's funny in a nerdy way because the hyperbaric is high pressure and the vac is negative pressure. So 2 opposite treatments that were, throw anything at it.
Yeah.
All right, and the vac's a bit cumbersome because you have a machine that's constantly pumping to create that negative pressure. But like you said, nowadays you can still walk around in it. All right, so that's it. That's
awesome summary.
Ulcers.
So the take-home message is, A, if you have venous disease, don't wait. And in our other video, we've talked about this too. So get it diagnosed, get it treated to try to prevent the ulcer. If you get an ulcer, don't despair. There are treatments which include treating the venous disease, but also there are specific treatments for the ulcer. But please see your doctor, get it addressed so it doesn't become a really big, potentially not solvable problem or a really, really complicated problem.
And key is prevention. Right?
Yeah.
That's what, like you talked about. And then treatment of it is just more of the prevention stuff, plus a little bit of wound stuff.
There you go. And if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
And thanks to Dr. Chuback for joining us.
Thank you.
Thanks a lot.
We'll see you next time.